Thank you so much, Dr. Buckley. And we'll ask Dr. Clark and Dr. Pereira to have their cameras turned on, and we will jump into some great questions and answers. I have a long list of questions here. We've obviously spurred a lot of conversation, which is extremely exciting. Thank you again for all of your work that you're doing, Norm, and the fantastic work of the the Chronic Pain Network, and how important it is for everyone throughout the country. You could see that map and how much funding is going around the country. Really quite incredible. I'd also like to welcome Tasha, bright and early. Thank you so much for being here with us. What time is it for you right now?
Too early, 2:30 a.m.
2:30 a.m. I mean, we're really honored and privileged to have you here today, Tasha. Thank you. And we will have questions. And basically, the way we're going to do it, panel, is that I'm going to ask a question to an individual, as that's where it was sent to. And then I'm going to get the rest of the participants to try to chime in a little bit. The first and most important question comes from Twitter. Dr. Andrea Furland asking Dr. Norm Buckley, why don't you have a Twitter account yet? The rest of the panel does. It's time for you to get one going. You don't actually have to answer that, Norm, but I thought it was kind of comical from our Twitter account. So starting with the first question, it goes to Dr. Pereira. Dr. Pereira mentioned a pain management course related to diet and to take those papers with you when you're going to the store. Sorry, someone's messing with this thing here. Thank you. How can we access these courses and papers?
Yeah, thanks very much for the question. I just want to say thanks to everybody on the panel. I'm really honored to be part of such an esteemed group. To answer the question regarding the course, this is a course that we have been creating for veterans with pain. The manual is almost done, and we will soon be able to share that manual with other pain centers at no cost. So that will be completely free. So we're getting ready to do that. The manual is about 100 pages long. It's not just nutrition. It talks about a variety of important topics. Anti-inflammatory diet is one of them. Of course, we've got the other pillars of health like sleep and so on.
Thank you, John. I've been lucky enough to take a look at it. It's pretty fantastic. And John and I both work at an operational stress injury program. One of the unfortunate difficulties is that there is no access to a multidisciplinary pain clinic in Calgary for veterans to get into quickly. So we often patch it up, but we can do so. And we have some excellent providers throughout the city that we can get them into certain pieces here and there. Okay, when it comes to veterans and it comes to treating veterans in the province, what do you see as the next big opportunity for pain research on a national level, Dr. Buckley? And would it include veterans in that process?
Well, that's an interesting layered question. So, and actually, it was interesting that you should mention veterans not having specific access to interdisciplinary pain care. That was one of the things we discovered when we went across the country, is that some of the provincially funded interdisciplinary programs were prohibited by their mandate from providing third-party funded service. So, for example, some can't provide service for workman's comp or motor vehicle accidents because that doesn't fall within the provincial mandate. And Veterans Affairs Canada, of course, provides third-party funding. It's great for veterans because they can access interdisciplinary care, but only through a third-party provider. And those aren't necessarily affiliated with the existing provincially funded plans in the provinces that support them, and not all provinces actually support interdisciplinary care. So, that aspect of how we would find clinics across the country, we've actually ended up having to reach out to a chain of community-based clinics or commercial clinics, CBI, which provides interdisciplinary care and are in a position to be able to work with third-party providers. So we have an interesting blend of some university and hospital-based clinics drawn out of the clinical research network from the chronic pain network and these community-based clinics. In terms of the next areas of research, one of the fascinating things, and this comes up constantly, is that even though, and not just in pain, but pain is the example I focus on, even though we know what constitutes optimal care for chronic pain, we are almost universally unable to provide it in a timely fashion in Canada. And part of that represents the training of primary care physicians. Part of it represents funding of different types of care, like psychological care, cognitive behavioral therapy, education, counseling, and physiotherapy frequently is not covered by provincial healthcare plans. So one of the areas of research actually is almost a policy research, first of all, which is how to go about providing care. There's some interesting projects being stood up now, not just with veterans, but in civilian populations also. That's actually an interesting word that's entered my vocabulary now, is veteran and civilian care. But the concept of stepped care, where you would, using online resources, do some initial screening, have patients, provide questions. One of the versions is even to interact with an artificial intelligence-driven, care bot, if you will, that as patients work through answering some of the standardized questionnaires, it will either give them advice or direct them to a provider who will then know that they've been triaged and then bring them into the appropriate level of care. And as you've said to me in the sidebar, one of the areas of, it's interesting because we identified the same thing. The problem for us was finding, in part, people who could support the third-party care. And you can layer on things like the interventional care and the medical interventions and counseling and so on. So I think that area of, if 20% of the population has chronic pain, you can't set up that many interdisciplinary pain clinics across the country and triage everybody in. Manash Wanier and Phil Peng redid Stop Pain, and we discovered that there are no more interdisciplinary pain clinics in Canada now than there were 12 years ago, which is stunning, but true. So that whole process, the policy process of stepped care, I think may be one of the biggest areas of research to come.
Thank you so much for that. Certainly, it's a mandate in Alberta to develop a hub and spoke stepped care, or what I like to call a tiered hub and spoke, starting at the medical home, where primary care is going to take the majority of this, working into primary care network treatment programs that are less tertiary care and still somewhat increased in their resources and ability to treat pain, moving into kind of your large tertiary hub. But I think you've identified clearly we have a problem with a lack of access for people living with pain. And I could imagine trying to put something together like you are. It must be extremely frustrating to see the interprovincial differences, let alone inside of the provinces, the intra-provincial differences from rural to urban, and even different urban differences, one city having completely different access and availability to another. Thank you for your leadership in this. And as someone who's treating veterans, I'm lucky enough to work on both the psychiatric part of it, the addiction part of it, and the pain part of it. But a lot of the times we're patching and trying to find different accesses and abilities. And many of our patients are also in rural. So I'm either trying to get funding to bring them to Calgary or doing a lot of fun work. So we can't wait for what's going to come out, and to have a standard of care and a center of excellence cannot be overstated for those veterans who obviously, as we saw in your presentation, have much higher risk factors of chronic pain, as well as mental health, trauma, addiction, and so many other things that come with it. Thank you for your leadership in that. I'm going to keep that question alive for the rest of the panel and see if anyone else wants to jump in. With or without veterans, what would you say moving forward on either your local level or on a national level is the number one priority we should be looking at when it comes to research in chronic pain? And feel free to jump in if you want, or I'll pick you.
Well, I might jump in if I could. I think I guess what's really exciting about all this work is seeing the tiered approaches that we have, the fact that we're understanding that policy changes are actually really critical to allow access, and seeing, I guess, nimble ways that different systems can adapt, because I guess I probably do expect that there will be differences in different places, just because inherently the same thing doesn't work everywhere. And one thing I think we've been quite excited about is coming at things a little bit from a grassroots type campaign or initiative. So the sort of idea of taking some of the knowledge that we have so far to people that are in areas that actually traditionally don't have access to some of those services, or might not be aware of some of that new research going through, because sometimes if we can get, I guess, campaigning for different things at numerous levels, us at maybe research level and working with government to try to change things, doing generally basic research, but then also getting, patients that, we see beautiful examples of this, such as, patient advocates like Gilletta, who's wonderful and I think really helps bring a voice to these different things. And so we do that, I guess, in a sense with an initiative called Pain Revolution, where it's really trying to go around to different rural and regional areas that often wouldn't have that information. So I guess I see really great opportunity in actually being able to marry some of these strategies where we're targeting grassroots and we're targeting policy to really have the biggest impact.
Awesome. Thank you so much. Really such a high level approach of looking at that. Dr. Clark, you're quite a researcher, leader, and clinician, one of those hard tripartites to find. What are your thoughts on moving forward with research in chronic pain?
I think that the thread is running pretty common amongst all the speakers here. And, Norm said that when you look at the numbers of multidisciplinary clinics and the Cadillac of care, the numbers haven't changed in 12 years. And I think we should stop trying to change that number. I think similar to what Tasha just said, what we need to do, and I keep having people reach out to me, how do you deliver your care model elsewhere? And I think we have multiple family health teams. We have lots of rural engagement of physicians and smaller health units that can totally benefit from the knowledge we have and be embedded into their program, either one with some specific expertise put into those clinics, and the advent now, we're in COVID times of virtual care, and really and truly we need to stop being afraid of integrating third-party applications and giving patients the ability to communicate with their docs. Instead of driving for 3 hours, they can actually communicate to you via their mobile cell phone. And the highest uptake that we're seeing for virtual technology and care, and I know people get their backs up about this, is in rural centers where folks can start to communicate with their docs without driving for 2.5 hours.
I think that's bang on. While we're trying to put this together in Alberta, we were hearing from patients that, up north, some of them will have to drive 2 days just to do a 15, maybe sometimes 5-minute appointment with their physician, and then spend the night and then drive 2 days back, taking an entire week off of work for one simple medical appointment. I 100% agree that telemedicine and virtual care and online apps are definitely going to be the future, and love to see more research into this. Thank you, Dr. Clark. And I know that Dr. Pereira is chomping at the bit to get in here. So John, happy to open it up to you.
Thank you very much. I actually wanted to talk a little bit about what we did June 26th. And I want to pay a compliment to Dr. 𝐂𝐂𝐑𝐈𝐁𝐄, who boldly took a step forward by hosting Let's Talk About My Pain Day. And in fact, it was for that day that I recorded the video on the anti-inflammatory diet. hundreds of people in Alberta connected via the internet to watch different healthcare providers lead different topics, from the cognitive aspects of pain to exercise aspects to the anti-inflammatory diet. And think about how efficient and how powerful that is, how less than a dozen healthcare providers in one single day could provide a service to hundreds and hundreds of people. And when we think about spread and scale of technologies and services, there's a real opportunity here. And what we've done this weekend with now thousands of people watching, including hundreds of people with lived experience, really speaks to this opportunity. And so when we think about stepped care, and I know a number of groups, including in Canada, like at the Ottawa Hospital, they recently published on their very impressive stepped care approach. At the base of that, at the base of the pyramid, the foundation should be online programs, pre-recorded, easily accessible, free to all. And when we think about 800,000 people with chronic pain in Alberta, 7 million in Canada, 1.5 billion, that's billion with a B, in the world, that's a lot of people. And the technology we have today did not exist just a generation ago, and we need to be harnessing that. So thank you, Rob, for what you did in June. Hundreds and hundreds of patients were watching that live stream in Alberta, and obviously what we're doing here this weekend.
Thanks for the plug, John. But, you know, at the end of the day, what matters most is the people that we're supposed to be serving. And in my mind, everything we're supposed to be doing is to help those who are living with pain. And that comes from education, that comes from policy, that comes from research. And whether it's directed towards healthcare providers treating it, at the end of the day, it's still to improve those who are living with it. You know, that was my passion for this conference. That was my passion for Let's Talk About My Pain. And that'll be my passion coming up soon, early 2021 with Let's Talk About My Headache. And it will always be dedicated to those living with pain. And we'll continue to move towards that. So moving on to the next question. Dr. Clark, is there a specific dose level where cannabis benefits are no longer obtainable? Is there too much cannabis? Is there not enough? Is it, this is really stacked, and hang in there. I'm sorry, Hans. I realize this is a no-no in psych training when I'm supposed to be talking to someone, is don't stack your questions. So I'll stop it at that. Do you worry about specific levels? And you can talk about THC and CBD at that and certain amounts.
Well, I mean, Rob, great questions. These are always common questions. I think the one thing, just as a general comment, we really need to stop thinking about cannabis as weed and as what people are smoking joints. And there's a significant dose differential. And unfortunately, when we talk cannabis, people think back to their 20, 30 years experience of what cannabis was known to be. And understanding the dose and what people are consuming is completely different today. And so it's a big difference if someone is consuming 1 or 2 milligrams of THC versus 100 plus milligrams in an entire joint of a 27% product. And what I'd like to say is those guidelines are not there. God forbid we end up in the era of take more because it will fix you. We've been down that road for 2 decades with the opioids. We are a much smarter medical profession now, I hope, that will never say things as there is no toxic threshold. We clearly know that high doses of cannabis are very bad for the adolescent brain, for the neonatal development of your fetus. And so there are pretty clear signals as to where you can have some harm. What we don't know, and I don't think we have an answer, is whether or not cannabis has cognitive effects at the doses being consumed with the plant-based products today. And so a big review by the Canadian Consortium for the Investigation of Cannabis basically found that, yeah, you've got harms from long-term use with COPD in patients, with respect to chronic bronchitis, cannabinoid hyperemesis syndrome, testicular cancer, male and female infertility, people who have a history of psychosis. Those are where we have to be really careful. But the adult brain, in terms of the plant products being consumed, we really haven't found evidence that there's a big cognitive effect long-term at the moment at the doses people are taking.
Perfect. You know, that really just answered another question that was here about cognition. And I love the twin studies where it came out with Dunedin saying, oh, you know, it's going to drop your IQ. Of course, the media said it's making you dumb and everything, because that's how we try to sell things. But twin studies haven't shown any of that. And excellent answer on that. You know, I'm going to follow up with that and be happy to hear from the rest of the panel. There are some bigger population studies that are showing those who seem to be using more cannabis and higher percentages of THC. So basically using cannabis all day throughout the day, often smoking and often high percentage THC, seem to have higher levels of pain and worse responses to it. You almost labeled it when you talked about using more and more of something, and we've been down that road. How do we actually figure out to do a good study at looking at that? And is there anything in the works at looking at comparing levels and doses specific to THC?
You looking at me, Rob?
Yeah, I'm looking at you.
Okay, so certainly there's lots of work ongoing. We actually have some animal models now where we're trying to have some equivalencies with respect to some of the opioid doses and look at potencies with respect to THC in particular. We know that CBD is more of a modulator of other neurons than it is actually having a CNS effect. You know, there's that dopaminergic supposition as well as the 5-HT supposition. So that work's ongoing for sure. You know, we continue to do human work in terms of the structured and validated questionnaires associated with this stuff. And I'm sure that Ramesh and Norm are busy with the vets and looking at PTSD and some of those studies going forward.
Awesome. Thank you. Anybody else want to comment with regards to cannabis, pain, and looking at research and levels?
Maybe let me get just a general comment, if I might, which is for the listening audience, cannabis is not one thing. And we often talk about it as if it is one thing. Now, in Canada, up until about 2014, if we talked about medical cannabis, it was a single entity. Health Canada sold one type of cannabis that you could inhale. And we could have a discussion about that. It had about 12.5% THC. It had very little CBD and so on. Now in Canada, there are hundreds of different choices. And in cannabis, we often talk about THC and CBD, and so we should. Those are two very important cannabinoids. But there's over 100 different cannabinoids in the plant, and that's not even counting all of the terpenes and other effects. And so I would say the following, which is when we have a scientific discussion about dosing and levels, we have to acknowledge that we're talking about different products. And when we talk about cannabis and the cannabinoids and terpenes, we talk about the entourage effect, about how some of these compounds may be working synergistically together. We are just at the start of learning about all of this. And I think that's what makes it so challenging. And so the take-home point is cannabis is not one thing, and the discussion needs to be so much more nuanced. We cannot give, unfortunately, these relatively blanket statements, if you will, that you see in the media, you see on the internet. Cannabis is all good, it's all bad, it helps this, it helps that, you shouldn't do this, you shouldn't do that. And I'm so glad that we have people, experts like Hans and Rob, and I've seen both of you present on cannabis, to give this more nuanced answers.
Thanks, John. You know, I think that the theme of every cannabis talk I've ever done is we don't know, because that's the reality of almost everything that people ask me. Well, we don't really know. We have a lot of population studies that there's so many variables. I mean, we don't know. We know that THC at low levels and small ends of studies or small numbers of people in studies seem to benefit, but how does that work in a larger population? We don't know. It seems that people report CBD works really well for some people in pain and as well as in mental health. And I was lucky enough to be involved in writing one of the first narrative reviews of CBD as an antipsychotic several years ago. And at that time, we had to do a narrative review because there was not enough data to do anything else. But the theme of that was we don't know. And it just seems to be we're still in that position. But because of leaders like Hans and the rest of the panel, we will get more of that information. We will learn more as we move forward. I'll pass that over to Norm. There was a great question about sex differences in response to cannabinoids. Another thing that we're learning about, Dr. Buckley.
Well, the reason I bring it up is because it does sometimes get lost in the whole lack of data about cannabinoids in general. But we've got one of our basic scientists has been looking at mechanisms of response to cannabinoids. And depending on what sort of responses you're looking at, male and female animals have very different capacities to respond, both in positive and negative ways. And it depends on the processes that are triggered. So whether it's if it's an immune-mediated response, male and female animals have different T-cell responses to the original inflammatory problem, and then the cannabinoids affect them differently. And so that really also has an impact, because it really means that if you're going to do this research, you can't just take a bunch of patients and say both groups look the same in their makeup. You have to actually do large enough studies to examine the individual subgroup effects, which in effect means doubling the size of many of our clinical studies.
So keep an eye out, Norm. We just got a paper. It should be out in the CJA. We looked at about 1,000 patients longitudinally in the province, and we found a sex effect for sure. So
excellent. You see, you can't pay for that kind of lead-in, hence.
Now, speaking of lead-ins, one of the difficult things I have with cannabis is talking to patients about, whether or not there's too much being used, whether or not it's being used as a way to kind of numb themselves, or even if it's starting to move into more of an addictive process. Really, we spoke about this earlier this week for the Western Canadian Addiction Forum. We spoke about cannabis and brief interventions. Recent data shows that doing a brief intervention that we would do with normal addiction doesn't work with cannabis. And often it's the ingrained culture of cannabis is good for me and good for everything. So we're still, even in the addiction world, still learning about cannabis because we don't know how to approach it. But it really comes down to language. And I think Tasha did an incredible job talking about the importance of language. I loved your knee and looking at x-rays. And I mean, there's nothing worse than when people with lived experience read their x-ray reports or read their MRIs, and, everybody's got degenerative disc disease and disc prolapses. And, I was putting in the chat line, as a 45-year-old, 67% of people my age walk around with degenerative disc disease, but certainly 2/3 of people my age don't have chronic back pain. And so I loved your wrinkles. I often use gray hair too, mostly because I'm turning gray. That natural aging. And I'm wondering, so the question is, what words do you recommend using so patients don't feel one is being flippant or dismissive in one's explanation of overprotection, especially if somebody has allodynia or hyperalgesia?
Yeah, I think that's a great question. And a really important thing is that we don't want to flip completely the other way, I think, and make people feel that whatever is there isn't valid at all, or that they're not being heard. I guess one of the ways that we sometimes go about this is explain, particularly if we're looking at imaging findings, is explain within the context that, when a radiologist is reading this and looking at it, it is their job to explain every single thing. But what they don't have time for, and probably also what we are less aware of before and more aware of now, is that just because these features are present, so some of these words that might sound quite scary and very full on, like degeneration or disc bulge or different things like that, what they aren't necessarily indicative of is telling us directly what's going on in our situation. So we've a girl in our group, Emma Karen, who's just recently finished her PhD, did some work looking at what happens if you reword these in ways that explain or shift things from degeneration to things like normal age-related changes, and found that basically that was much more reassuring to people, but it was still acknowledging that those things were there, acknowledging that this is overall generally what we see, but that trying to place it into a context that is, captured by the general research. And I think some of this probably too is us, determining to what extent to that person is this problematic.
Mm-hmm.
If they've not read anything into this, if there's nothing that is making them feel worried or nervous, it might not be that this is really the key thing to focus on for that person. I think it's relevant to know that generally those things can impact the experience, both from a basic level, where we see, heightened hyperalgesic responses to a standard stimulus. But if it's not key to them and to their story, then that might not be a point that we have to focus on as much. But I think it is discussion actually of some of those concepts with people, because I think we tended sometimes to almost stay away from discussing more complex things such as allodynia, which I would actually still argue we don't have a perfect understanding of. But going in and recognizing that actually, people are really cued in and switched on when it comes to that. We just need to take a step back, I think, and explain this in probably terms that are accessible for them. But I think it's a really important thing to keep in mind that there's the balance between not over kind of stating and making it feel as though I don't feel validated. I don't think you've heard me. And then actually, trying to, if it's a problem for that person, discuss that fully and ask them, what do you think? What did you think when you read that? What did that mean to you? And then have a discussion that's evidence-based on that.
Yeah, I like that. I like the idea of also giving the ball back to the patient to let them explain to you what it means and what it affects them. I would love to see the terminology degenerative disc disease simply just removed as a whole. I work with spinal surgeons, and certainly when I used to use the word failed back surgery syndrome, they did not like that, and are certainly very much against that concept. And for good reason, because they bring it back to me. Is there such thing as failed knee replacement surgery syndrome, or failed hysterectomy pain syndrome? And the reality is it's just post-surgical pain and persistent post-surgical pain. Something Hans probably knows more about than the rest of us. But I've learned to shift my terminology and not use that diagnosis anymore. I'd love to see the same thing of degenerative disc disease just turning to, normal degenerative changes that we'd expect to see. We see some differences too, as if it's an interventional radiologist looking at, hey, maybe the next thing is an injection here, rather than just, okay, I just want to know what's in the actual MRI or X-ray or anything like that. I would like to shift quickly to, a lot of the virtual reality you're using, Tasha. I mean, I'm going to let the cat out of the bag. I was hanging out with Pam Squire and Owen Williamson not long ago, and we were talking about virtual reality in chronic pain and kinesiophobia, and using video games and then letting people see themselves moving so that they can reinterpret themselves as, oh, I can do that. And one of the worst parts is the medical legal exams and someone struggling with kinesiophobia and then saying, oh, they're faking it. And they're not faking it. They're scared. Oh, well, no, when they were walking away and I waved, they turned around and looked fine. They're no longer scared at that moment. I mean, really trying to help some of our medical legal examiners understand the psychology of pain and the fear of movement and how we might be able to break that using virtual reality. And certainly, I mean, mental health, we've looked at it, in PTSD and using virtual reality for that. We're seeing more and more virtual reality. I'm curious from the panel, do you see virtual reality becoming the future of a lot of the treatment in pain and moving forward in treating pain? And I'll start with Tasha because you're already there. But have you seen a lot of uptake in other people and other clinics using what you guys are doing?
Yeah, I think we probably sit at a balance between, getting equipment that is simple, works really quite well, and then also having versions of it, which allows us to really do, very nuanced research and control for a lot of different variables. So a lot of stuff that I work on, they're quite complex systems. But I do see that there is merit and value in being able to take some of those different things to the clinic. And I think you hit the nail on the head with some of the work looking at, movement related fear or pain related fear. I think there's value in using some of those things, because I guess coming at it from a physiotherapist lens, we will often give people exercises to do that have the overall aim of helping to reduce fear of movement or just increase general movement function and capacity. And inevitably, those exercises often stop being done. And in the past, I think we put that onus on the patients. Well, it's your job to keep up with these exercises. But I'd say that onus is on us. If they're boring, if they don't see value in them, they're not going to be done. And that is inherently true across all of that, myself included. And I think that's where some of the virtual reality things actually does have real capacity, because it's engaging. You're giving someone this experience where they have all these different things happening. You're, flooding their brain with, happy hormones, giving all these, different experiences that I think we can use to our advantage when we're getting people to do things that can be scary and then they can be hard. I think probably what's quite key is knowing whether what we see people performing or able to do in virtual reality extends beyond into the real world, because I think that is a pretty key aspect of it, and it almost alludes to the example that you gave, where they can't do this, but then when they are in the parking lot and thinking about something else, they're able to do it. And I'd argue virtual reality does provide a distraction, certainly, and we need to ensure that the mechanisms are beyond distraction so that we have real world impact.
Oh, I like that. So it's not just the distraction; we got to add the treatment to it too. Dr. Clark, you were unmuting, and then we'll go to Dr. Pereira.
I guess I want to give my hats off to Tasha for the work she's doing in the innovative research. I'm going to be controversial, as I know I tend not to be sometimes, but what I'm really tired of are my patients believing that physiotherapy for all will fix everything. And the one thing that we need to do is have more research around specific treatment regimens before we send people down this, Norm touched about the third-party payer scenario, and not all physiotherapy is the same. And you must lead with research, and Tasha is doing that. And there's no doubt that her work is going to lead to changes in care and improvement in pain and improvement in function. And so as a program that, that tends to do new and novel things, we're not implementing yoga for everybody until we do the research, or clinical hypnosis and I got a question yesterday at the Atlantic Pain Conference about, chiropractic and chiropractic care for all. Let's do the research, let's move it forward, and absolutely, patients can benefit from a huge host and modality of care, but let's just have the evidence before we do that. And I think that's what we're all here to do. And looking forward to moving and bringing new innovative strategies to patients, then disseminating it, as we talked about, across the country.
Love it. Dr. Pereira.
I think virtual reality is absolutely going to be a modality for the treatment of pain soon. While the technology is still expensive and so forth, like anything in technology, it's rapidly improving, costs are coming down, and we are beginning to see from various studies the kind of detail we expect from a treatment modality. For example, when we look at stress and the effects of how VR can reduce stress, people do better in a naturescape than a cityscape. And that's really interesting. It means that the technology is not just a mere distraction, no matter what you're showing people, but rather it has that nuance of, okay, you're seeing trees and forest and beaches, and that makes a difference compared to you are seeing tall buildings and cities and so forth. And so I think that's really fascinating. And when we think about the evidence we already have for the effects of being in nature on the brain, and being here in Alberta, we have a huge advantage, being right next to Banff and Jasper and so on. This is really exciting. And I think that from a virtual reality perspective, from a rewiring the brain perspective, from a neuroplasticity perspective, I can certainly envision soon people going to pain centers, which might be able to afford some of this expensive equipment, putting it on, trying it out, seeing how it affects their pain. Nothing works for everybody, but nevertheless, when we think about how much cell phones have evolved in the past decade, I can only imagine for VR. Rob?
You know what? The one thing I like about this conversation is we're, again, really focusing on how something can be used as a novel treatment to make a difference in someone's life. I often get stuck thinking systemically of how do we roll that out? Obviously, VR programs are expensive, and this is that important model of having what we're looking at as a tiered hub and spoke, where we really need to improve education at primary care, where the vast majority of treatment can be done. We need access to physio and psychology in many of these cases. So a lot of pain can be treated at the primary care level. And then, secondary care for those who maybe it's a little bit more difficult, maybe there's more complexity. And then our tertiary centers, we need these absolutely top-end, high-end treatment platforms. I mean, to see a tertiary center that just focuses on physio and psychology, in my mind, that should be primary care spot. And we should be looking at the most innovative processes and looking at all different, and we know anybody who tells me there's one way to treat chronic pain doesn't know anything about chronic pain. There is a multitude of different ways, and we have to try to figure out how to individualize that. And that's where the research has got to bring us to, is to understand who's going to respond to what, whether it's genetic testing, which we're a ways away from and understanding, whether it's as mentioned by Norm earlier, sex differentiation, whether it's age differentiation, whether it's the different type of pain modality. We're still struggling to even correctly classify a lot of the time what we're doing. And many of the times I still see referrals for chronic pain syndrome. And then I got to dig out, okay, this could be so many things. What am I looking at? But the reason I look systemically is to think about, the individual who's on a fixed income, who can't really afford to buy a virtual reality helmet, can't afford to pay for physio and psychology. And the only thing that's covered is their medication. And so one of the questions that was posed that I thought was excellent is, Dr. Pereira, do you have strategies for individuals on a fixed income to have a better anti-inflammatory diet? Processed food is cheaper, easier to access, and available everywhere. How do we shift that thinking, and what can we do differently?
Yeah, you're asking a really great question. And, I have an answer insofar as one of my favorite things are foods in cans, and I buy them myself. And let me tell you why. The best recipe is no recipe at all. The best recipe are things that you can easily access, that don't cost a lot of money, and are ready to eat. And virtually everything in a can is already cooked. That's part of the canning process. And so as you go around your store looking at various things to buy, spend a bit more time in the canned goods section. They are cheap often. They can be stored for a long period of time, which saves you money because you're not constantly throwing out spoiled food and so forth. And because of the canning process, the way it sterilizes and so on, you don't need to use often preservatives and so forth. So when you think about how to save money in these tough economic times, canned foods can often be a great choice. Similarly, certain jarred foods that have already been cooked, you just twist open the lid and you can warm it up in a minute or two and start eating.
Thank you so much. I could do this all day. I'm sorry, we're right at that. I know it's 3 a.m, so I feel like I should just let Tasha speak. So I'm going to give Tasha 1 second or not 1 second, but I'll give you a couple of minutes quickly, Tasha, because it's 3 a.m. and you're up with us. Why would I cut you off? So go ahead.
I'll be quick. I just wanted to follow up with what John said. Is I do think that there actually are quite cheap and accessible VR options in terms of using your own mobile phone within Google Cardboard, and they have lovely on YouTube different where they give you binocular vision that you can basically then see VR. So if you're in the city, there are VR of nature, of different environments. So I think probably we can be of assistance in helping create those resources that are available to people so that they have those options should they like to try them. But thank you, Rob. This has been incredibly fun.
Oh, thank you, Tasha. Thank you to all 4 of you. This has been incredibly important for all of us to sit and listen to and learn from a systemic approach all the way down to the most innovative processes, and what we eat makes a difference. I really appreciate all four of you being here with us. And again, for everyone watching, all of our speakers are here today and not getting paid anything. They're volunteering because they know the importance of disseminating this information and improving outcomes for people living with pain. The Pain Society of Alberta and I thank you all and really do appreciate you taking the time out of your important day or night to be with us. For everybody watching, please remember to please visit your exhibitors. It's literally right there. You can scroll down, click visit the exhibitors. We couldn't have done any of this without our exhibitors helping and supporting us. So please check them out. And again, a big thank you to our gold exhibitors, Teva and CDC. Hopefully CDC is listening and we can talk about the MRI reports. But at the end of the day, CDC has been an incredible partner to us for many, many years. And really, I can't do a lot of what I do without them being in our community. So thank you to both Teva and CDC. And we'll have another lecture coming up soon with Teva. And from this point, I'd like to introduce Shelley Prosko. I'm not going to go into too much of an introduction because she's speaking later, and why would I ruin the opportunity to give a bio then? So here's the next movement break, and we're going to have Shelley Prosko, an Albertan physiotherapist, do that. And we will be back at 11:45 with the Mayo Clinic's Dr. David Dodick, where we will spend most of the rest of the afternoon talking about headache. So if headache is important, which I know it's something we see all the time in pain, hang in there. I'm sorry, that's 11:30. 11:30. We'll see you at 11:30 and enjoy your break.